I don't think we have a great sense of what the true prevalence of depression and burnout is in our field at this time, but I think we have some indication that they are both high and that there's subgroups that are particularly more vulnerable than others.
The reason all of these things connect is if you think about the future of psychiatry. The future of psychiatry is women, younger psychiatrists, and diversity and inclusion and minority psychiatrists. So if these are the people who are most affected by burnout and by depression, we have a particular challenge.
That's Dr. Richard Summers and Dr. Constance Guille talking about their article on the prevalence of burnout and depression among psychiatrists. Their work appears in the October 2020 issue of the American Journal of Psychiatry. I'm Michael Roy, Executive Editor of the American Journal of Psychiatry, and this is AJP Audio. Dr. Richard Summers is Clinical Professor of Psychiatry and Senior Residency Advisor at the Perelman School of Medicine at the University of Pennsylvania. He is a Distinguished Life Fellow of the American Psychiatric Association, currently is Treasurer of the American Psychiatric Association, and he recently served as Chair of the APA Board of Trustees Workgroup on Psychiatrist Well-Being and Burnout. He has published widely on topics including psychodynamic therapy training, the Therapeutic Alliance, psychodynamic formulation, positive psychology, and psychiatry residency training. Dr. Constance Guille is a professor in the departments of psychiatry and behavioral sciences and of obstetrics and gynecology at the Medical University of South Carolina. She served on the APA Board of Trustees Workgroup on Psychiatrist Well-Being and Burnout, and she is co-investigator on the Intern Health Study, a large prospective study examining stress and depression among medical trainees. She directs the Women's Reproductive Behavioral Health Division at the Medical University of South Carolina, and has published widely on topics including women's health, stress, and depression. Dr. Summers and Dr. Guille are co-authors of an article in our October issue entitled Well-Being, Burnout, and Depression Among North American Psychiatrists, the State of Our Profession. Dr. Summers also wrote a commentary on this topic that appears in the October issue entitled The Elephant in the Room, What Burnout Is and What It Is Not. Dr. Summers, Dr. Guille, hello, and welcome to the podcast.
Thanks so much, Michael.
Hi, Michael. Thanks for having us.
So as I mentioned in your introductions, you both participated in an APA Board of Trustees work group set up in 2017 at the direction of Dr. Anita Everett, who was then president of APA. Could you begin by telling us why this work group was formed to examine well-being and burnout among psychiatrists?
So at the time, there was increasing recognition that burnout was a big problem. It was more and more prevalent. People were talking about it. There were studies looking at burnout in medicine in general. And the question arose, kind of what's happening in our field. Are psychiatrists, like all of our colleagues in the rest of medicine, struggling with burnout? We always tend to think we're a little bit unique. Maybe we're different. Maybe things are different for psychiatrists. And before, as a profession, we sort of embarked on figuring out what to do about burnout. There was a sense that we ought to try to define a little bit more what was going on in our field. It also was something I think APA thought would be a valuable thing to do for its members as a sort of a service to the field. And then it really laid the groundwork, in a sense, for a very current conversation about COVID and the pandemic and the impact on the profession.
Indeed, and we can definitely return to that because it's probably important to mention that the survey did take place before actually we were all trapped in our homes. Now, your article notes that it's not exactly easy to differentiate burnout from depression. You write that burnout may be regarded as an experience rather than as a diagnostic entity, while depression reflects specific diagnostic features. Could you go into a bit more detail about the distinction between burnout and depression? And as a follow-up question, is there a general agreement in the field on how these two constructs are related?
Sure. So that's a great question. Burnout is commonly defined as a work-associated syndrome where depression is a disease. So burnout is very situation specific and often very driven by demanding work environments and coupled with insufficient resources. Whereas depression, in contrast, is a disorder. It has well-defined diagnostic criteria, and importantly, it can occur independent of stressors. Although stressful life events are important in the etiology of depression, you can have depression without that situation or environmental factor. So as you mentioned, there is some debate in the field as to whether there is an association between burnout and depression, and there's arguments on both sides of that. So some authors will argue that depression and burnout are categorically different, that the context and the quality of distress that people experience when they have burnout are fundamentally different than depression. Some argue that burnout and depression, they don't have shared vulnerabilities, they don't have a shared underlying mechanism. So that's one side of the picture. On the other hand, there's definitely arguments that depression and burnout are very similar constructs. They do have a shared vulnerability, which is stress. And a number of our studies, I'd say the majority, but there are still some that do not show this, show a very high correlation between depression and burnout in the majority of studies, but again, not all. So some suggest that there is considerable overlap between the two.
Okay, so it seems that there's a range of opinions when it comes to defining and studying the relationship between burnout and depression. So before we get to your work in particular on examining burnout within the specialty of psychiatry, what has other research shown when it comes to the prevalence of burnout among physicians in other specialties?
Yeah, so that's a good sort of important context question. So, and when we embarked on the study, it was sort of after the classic Mayo study that really looked quite widely, measuring burnout across medicine, and then with results broken down by specialty. And basically, depending upon the specialty, the rates of burnout as defined in that study were sort of between the 40% and 60%. And it was an interesting topic sort of for a conversation at the time, that psychiatry actually was and sort of is regarded as a lower burnout specialty. Slightly greater satisfaction with work-life balance, lower rates of burnout as defined in that study. And this was the study that also really showed that there was a marked increase in burnout from 2011 to 2014. And that was really the sort of the beginning of the sort of so-called burnout epidemic. Interestingly, when the Mayo folks did a follow-up study looking at what sort of essentially sort of following up with the same individuals or the same population in 2017, although there was a significant increase in medicine in general from 2011 to 14, from 14 to 17, the results seem to go back to the level of 2011, which is very interesting. And again, like so many of the things as Connie was talking about, new information, in a sense, they raise more questions than answers. Is that because people are getting less burned out, or is that because people are adapting to the changing context and in some ways not expecting quite so much? So the bottom line really is that we're sort of in it with the rest of our colleagues, although perhaps for some interesting reasons, struggling a little bit less than many in medicine.
So turning now to your work, your study aimed to evaluate the prevalence of burnout and depression among psychiatrists. It also looked at demographic and work factors that were connected to burnout and depression. So first, could you tell us how you and your co-authors went about collecting data? And second, what measures you used to quantify burnout and depression?
So we really, in a way, Michael, we actually had two missions. One was to open a conversation in the field, to really get people thinking about burnout and reflecting on their own personal experiences, as well as kind of what's happening in their workplace. And the other was to do research and collect data. So we created an online survey. And the online survey asked for a variety of sort of demographic characteristics, and then included a scale related to burnout and a scale related to depression. I'll come back to that in a moment. And we designed it so that the experience of individuals who came to the survey would be that they would sort of enter data, but they would get immediate feedback on their sort of burnout and depression scores and get an immediate comparison with all the other psychiatrists who had completed the scales. Because the notion really was that it would aid in the process for individuals of sort of thinking about how they feel. And I must say, even after having being immersed in the field myself, when I took the burnout scale, the depression scale, and took them again a couple of times, it really did make me think a little bit differently about my day and my week, and just sort of allowed me to take a little bit of a step back. So hopefully the many people who went and answered the survey really had some revelatory or at least meaningful experiences doing the survey. We publicized it pretty widely, a lot of blast emails from APA. We had a number of town halls at the APA annual meeting and the IPS meeting. We did a bunch of social media stuff, and we tried to really drive a lot of traffic to the survey. And I think we were pretty successful in doing that. So the two scales that we used are the Oldenburg Burnout Inventory, and there are really two main scales that are used in the literature, the Oldenburg and the Maslach. The Maslach perhaps used slightly more widely, the Oldenburg perhaps used a little bit more internationally. The Oldenburg also includes some items related to well-being and not just burnout. So for that and a variety of reasons, we selected the Oldenburg scale. And then the PHQ-9, which is probably the most widely used depression screening tool. And I think in a way that was sort of an easier choice.
Now, you mentioned in the data that you collected for the survey, I'd like to touch on the demographic characteristics of individuals who responded to this survey. What was notable to you and your team regarding the sample population?
So, of course, we looked at the characteristics of our respondents and compared them to the overall characteristics of APA members. And our responses skewed in the direction of being more female and younger and more trainees. So both more resident fellow members and more early career psychiatrists. In a way, that's not surprising. Those are the folks who we have learned are at greater risk. It was clearly more on their minds, I think, and they were probably more likely to respond. But I think it's also a topic which is a much more salient and sort of immediate topic among younger members of the profession and perhaps women.
Time to dive in and get to the results of your work. What were the demographic and work characteristics that were associated with burnout?
Sure. So the characteristics that associated with higher burnout scores included higher depressive symptom scores, female gender, inability to control one's schedule, and work setting. So if you are more likely to be working in the community as opposed to an academic setting, you're more likely to experience higher symptoms of burnout.
And looking at the other side of the coin, what were the demographic and work characteristics that were associated with depression?
So depressive symptoms were associated with higher burnout scores, female gender, being a resident or in your early career stage, and then also being in a non-academic workplace setting.
And did any of these results stand out to you or surprise you?
So I'm going to take that, but I'm kind of curious about Connie's thoughts about this as well. So I think the things that struck me were the gender finding. Now, it struck me not in the sense of being surprised, but by the strength of the finding and in a sense, the importance of the finding. There are many reasons why female psychiatrists probably are at greater risk for burnout and for depression. But seeing it and seeing how significant the finding is, I think is really something that drives our attention and really need to take some action. Also, of course, struck by the age issue. I mean, burnout, the term sort of connotes more, like guys like me, people who've been doing this for a long time and they get sort of tired of it or something like that. But that's actually not the people who are struggling with burnout. It's really the younger members of our profession. I should say as an important additional note, the second phase of the committee's work was to take up the issue of burnout and depression among minority psychiatrists. There is some suggestion in the literature that minority physicians are at greater risk for burnout and depression. The literature goes both ways, and we are particularly interested in that in our field. And the reason all of these things connect is if you think about the future of psychiatry, the future of psychiatry is women, younger psychiatrists, and diversity and inclusion and minority psychiatrists. So if these are the people who are most affected by burnout and by depression, we have a particular challenge, kind of an incredibly important challenge in addressing that. I know from our conversations and from Connie's background and experience that she's got some interesting reflections about the whole gender relationship with burnout. And I don't know if you want to say something about that, Connie.
Sure, I'm happy to. Well, so, in terms of female gender being a risk factor for depression and burnout in our sample, that wasn't surprising to me at all. We know in the general literature that female physicians are at greater risk for depression and burnout. That's a pretty consistent finding, and so it's just being reflected here. This is something that we've looked at a lot, especially in training physicians, and again, see gender differences in depression and anxiety. And one of the factors that I've been investigating has to do with what's called work-family conflict. So work is negatively impacting your family life. And so that gender difference that we see in depression among medical trainees, actually we can account for more than a third of that relationship by just looking at work-family conflict. So it is a really important risk factor for depression for both men and women, but seems to really be explaining that gender difference in depression. Following up on that, we've been tracking a cohort of medical trainees out past their residency and looking when they're actually in practice and what's happening with gender differences in depression and work-family conflict. And interestingly, the gender differences in depression start to go away and work-family conflict starts to go away. And we were really kind of intrigued by that because you would think it would actually kind of get worse as you're getting further out in your practice. But what we found is that as soon as residency training was ending, actually a large percentage of women were already going to part-time work. And at 6 years out of training, there was very large gender disparities in part-time work in men and women, and considering part-time work, where almost 3/4 of women were either working part-time or considering part-time work in comparison to men. So women are really addressing their work-family conflict likely by changing their work schedule, which is working less. And as Rick mentioned, that attrition from medicine and attrition of women from our field is a really concerning issue.
And are there any limitations to your study that may have affected what you and your team found?
Sure. So I think there's inherent limitations to studying burnout in and of itself. We know in the field that burnout is not consistently defined. We did a large systematic review, actually, of all studies looking at the prevalence of burnout physicians. This was led by Lisa Rodenstein. And in over 180 studies, we found over 130 unique definitions of burnout. So there really is not a clear definition of burnout in the field. So when you're studying it and trying to identify factors that associate with it, you're going to have some variability and some challenges and some limitations. I think, as Rick mentioned, also, we probably have a bit of a selection bias in that, the people that ended up having the greatest risk for depression and burnout were also the people that were filling out the scale and probably just are more interested in this topic. So, I don't think we have a great sense of what the true prevalence of depression and burnout is in our field at this time, but I think we have some indication that they are both high and that there's subgroups that are particularly more vulnerable than others.
Can I just comment in support of the findings of the article? Although there are some of those limitations with the sample, I think we do have the conviction that because of the statistical analysis, we were really able to demonstrate that the findings related to gender and age, we believe, are genuine findings and not simply a reflection of sample bias.
And so as we start to wrap up here, I'd like to place your findings in context with previous work. We mentioned earlier that burnout is difficult to characterize and that various reports in the literature do not exactly agree about the overlap between burnout and depression. How does your work fit in here?
there are two findings that we feel are significant contributions to the literature. One, because we were studying both burnout and depression in our population, we were able to do some analysis of the relationship. And we found that for individuals who screen positively for depression, virtually all of them are also endorsing positive burnout scales. We also tried to look at the question, there's been a little bit of, quite a bit, let's say, of publicity about the potential relationship between burnout and suicide among physicians. And as we all know, there are a tragically large number of physicians who take their lives every year. And the question about the relationship between physician suicide and burnout is an incredibly important one. And there is a claim that there's a sort of close relationship between the two and that burnout is an important contributor. And we tried to look at that question. And what we did was we pulled out the suicide screening question on the PHQ-9. And we really tried to look at what some of those relationships were that correlated with the endorsement of suicidal thinking or intent. What we actually found was that depression, not burnout, seems to be that essentially when you capture depression as a potential cause or sort of association with suicidality, that burnout starts to drop away. So that the idea that burnout per se may be a predictor of suicide was less supported by our findings.
And what would you say are some of the implications that your study has, first for healthcare organizations that may be looking to address burnout among their employees, and second for workforce policy in general?
Yeah. So when I sort of try to condense it down, and of course this is like, what is the real, what's the real policy implication of this work? I think it's for healthcare systems to look first at two major interventions. And those interventions are setting up mental health services for their physician employees. Of course, this is probably true for all healthcare employees, but I'm just addressing physician employees that are very accessible and confidential and of high quality. The second, and this I think relates to the strong empirical findings Connie was talking about before, to look at their parental leave policies. And that's really something a healthcare organization actually has control over and can do something about. And by making parental leave policies that are more family friendly, that can potentially have a big impact. So those are sort of policy implications on the healthcare system level. But a lot of burnout, it's sort of like they say, all politics is local. A lot of burnout is local too. It really has to do with the particulars of the workplace. So at the level of departments, at the level of clinics, of programs, of training programs, et cetera, the practice of setting up committees and processes to look at well-being that are simple, collaborative, and sort of iterative, taking a problem, working on it, looking for improvement, and then trying to take the next one, is really what you can do on the sort of more micro level. So those are the two.
And I think Rick kind of spoke to this a little bit, but anytime we are screening for burnout, we should also be screening for depression, that the two really need to go hand in hand. And as Rick pointed out, there needs to be a clear pathway that is accessible and convenient and confidential for treatment for depression. I would also extend, beyond the policy of parental leave. When we look at our studies, we're not just talking about people that are parenting having work-family conflict. It's actually more specific to gender, where women are more than likely to take kind of caregiving roles. And so it's not just about having children. And the policies that I think really need to shift, we need to catch up with our demographic in medicine, where the workforce is half women at this point that are graduating medical school and going into the workforce. And we really have not changed the structure of medicine as that demographic has shifted. So creating more systems and policies that would support more of a work-family balance for both male and female physicians, I think would be advantageous.
And actually, if I can add something as well, I think the other implication, not a policy one, but a clinical one, is that in the clinical evaluation of physicians who are struggling with burnout or depression, that we need to look at and think about both, whatever the presentation is. For the physician who presents with depression on the surface, we need to make sure that there's a lot of attention to workplace factors or work-related stress. And for the person who presents with burnout, we need to make sure that the focus on the workplace issues doesn't obscure a really thorough and thoughtful diagnosis and potential treatment for depression.
Now, Dr. Summers, the October issue of the journal also includes a commentary that you wrote where you identify 8 things burnout is alongside 8 things burnout is not. What are key points here that you would want researchers, clinicians, and other mental health professionals to take away from the commentary?
So I think, as you can tell already from our conversation, I think one takeaway is we are struggling toward a clearer definition and understanding of what burnout is. But I believe that the attention to this area, the work that's been done, has already had a salutary effect on the profession. I think that we have been able to, and by we, I mean many people who are working on this issue all over the country and internationally, we really have opened up a space in medicine and in the culture of medicine to have conversations about the stresses and strains of being a physician in a culture that, has typically not been very friendly to that. It's been seen as complaining. It's been seen as not really kind of with the program. And I think that what we're really trying to do is to recognize and I think make common and positive the notion that when you talk about the problems, that actually opens the door to addressing the problems and to ameliorating them, rather than just being negative. So I think that's sort of a meta point that I really do hope comes across. I mean, I guess the other thing, it sort of strikes me on rereading the viewpoint, it's almost a little bit quaint. It's almost like it was written in a slightly different era, pre-COVID, because it's, as a profession, however much we were struggling before, we've gotten a major stress test. And this is for all the reasons that I think I don't need to enumerate here, including great concern about personal risk for healthcare providers on the front lines, the exacerbation of existing work-home tensions, the whole notion of moral injury, being asked to do things that you may have strong feelings about the way the country overall has handled the pandemic, and the implication of that is that it may be putting you at slightly greater risk yourself and the feelings that come with that. And so I think, it sort of sets us up for hopefully a constructive conversation that I think our healthcare workforce is coming into this era. And by the way, I believe that as a profession, psychiatry and medicine and healthcare, we've stepped up incredibly during this pandemic. But we've done it already limping to some extent. And I think it's going to be really important to try to continue to address these issues and to understand a little bit more about what the implications of the pandemic are going to be in terms of how they last. As we know, everybody can rise to the challenge in an emergency for a little while. And then the adrenaline starts to wear off. And I think as we head into the fall, and we're sort of looking at the continuing pandemic, people having come into it with burnout, I think it's going to be very important to have a lot of continuing attention to this issue.
And finally, back to your research article. The article ends by naming 5 directions for further work in this area. And I think it's a good way to wrap up this conversation as well. Could you describe these 5 recommendations?
Sure, I can summarize these. So I think overall there's a lot of work that needs to be done to understand both the individual and workplace factors that predict burnout, depression, or suicide risk, really so that we can develop preventative interventions and implement those in medicine. I think that right now our data is very hypothesis driven. So we are kind of picking the factors that we think are involved in these things and studying them when there's some biases in that. And really If we could start leveraging some larger data sets that look at many variables and taking a more agnostic approach to the data and through statistical analyses and having the data kind of tell us what are some of the factors, either individually or in combination, that are contributing to this risk. I think that'd be a very important area of investigation. A second, as Dr. Summers already alluded to, is that we really need to do a deeper dive into understanding minority and underrepresented groups and their experiences in medicine and psychiatry and how that's potentially impacting burnout, depression, and attrition from the field. And while I think our quantitative data is great, a nice complement to that is using qualitative data, doing key informant interviews or focus groups to really get at some of the nuances and some of the themes and some sub-themes that are contributing to these outcomes. Another area I think is very important is in studying interventions to alleviate burnout and depression. There's been a big focus on individual interventions when we know that the kind of healthcare system level factors are really important, and we need to be starting to look at more interventions that alleviate some of those stressors in our healthcare system as interventions to reduce burnout and depression. And then lastly, getting back to the issue that I think that we've kind of touched on already is really better understanding this relationship between depression and burnout. And I think we're really only going to be able to do that if we have large prospective longitudinal studies where we can really look at that temporal relationship between burnout and depression and how they overlap and affect each other over time. So those are really kind of more research agendas issues, but definitely I think those 5 key areas would help move the field forward.
Dr. Richard Summers and Dr. Constance Guille, co-authors of an article in our October issue on the prevalence of burnout and depressive symptoms among North American psychiatrists. Thank you both for speaking with us.
Thanks for having us.
Thanks for having us. Take care of yourself, everybody.
This concludes this episode of AJP Audio. You can rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. Please also visit our website, ajp.psychiatryonline.org, to check out trending articles, find CME courses, and watch videos highlighting some of our other articles. APA Publishing has other podcasts you can listen to. Psychiatry Unbound is the books podcast from APA Publishing. It's hosted by Dr. Laura Roberts, editor-in-chief of APA Books. Also check out From Pages to Practice, which reviews the latest research published in the journal Psychiatric Services. It's hosted by Dr. Lisa Dixon, editor-in-chief of the journal, along with Dr. Josh Beresin. You can subscribe to these podcasts on Apple, Google, Spotify, or on any of the popular platforms. Next month in AJP Audio, we'll talk with Dr. Rajita Sinha of Yale University about her research on the use of brain imaging in the evaluation of drinking outcomes during early outpatient treatment for alcohol use disorder. We hope you'll join us too. Thank you for listening.